Okay, so hello everyone. This is Daniel Shahid, and I am a fourth year medical student. This is our series of cardiovascular question solving from USMLE Step 1. And we apologize for poor audio quality in our previous lecture, but I hope that I'm audible to everyone and understandable to everyone in this lecture. Okay, let's move to our first question. Uh, a friendly advice to you that whenever you got a quite case series or case in which you got ECG, you got picture, you got labs, I strongly recommend to look over those labs first because looking at those labs or those pictures will give you an idea within a second that what is actually going on. It might give you an idea at a glance, literally. Looking at the ECG, okay, I'm looking at the ECG. I looked at the ECG, I loved it. Okay, of course, it's not good for the patient, but it's good for me to understand. Okay, now reading out the last line, which of the following mechanism is most likely responsible? Cool. Now you can skim the options. I give you 10 seconds for that. Okay, let's read this case together. So, first of all, what we got a 16-year-old boy with no medical condition is brought to the clinic after an episode of palpitation. He was sitting in a movie theater when his heart suddenly began racing, accompanied by lightheadedness. Remember for the rest of your life that whenever you got a young patient and that young patient has syncope, and that syncope is followed by or you can say that prior to that syncope the patient have a history of palpitation or anything like that, so think of certain tachyarrhythmia. Literally this is a huge giveaway, and keep that in mind for the rest of your life, not only for the step one but also for your clinical exams and as a doctor too. Okay, so the patient denies chest pain or shortness of breath. Cool. He recalls having similar episodes of rapid heartbeat in the past, often during periods of academic stress, but without associated symptoms. Seems like that this thing is also associated with certain triggers. Pretty cool. Okay, so physical examination is normal and you have given the ECG. Okay, now if you look at the ECG of this patient, what this ECG is showing you. First of all, if you look at what's everything is normal in this ECG except for the PR interval. Why? Because you can see that PR interval is shortened. First of all, the PR interval is shortened. Secondly, you can see a change here. Anything which is not normal is which is of course you can see a delta wave here. Now, what is delta wave? This is a delta wave. Delta wave is a slurred upstroke of the QRS complex, which is seen classically in Wolff-Parkinson-White syndrome. Okay, now I'm gonna go into the detail of that. But now I have given you now association of Wolff-Parkinson syndrome with delta wave. Okay, you can also see Wyden QRS complex here. Yeah, you can see appreciate. I think I you can appreciate the Wyden QRS complex here. It is not normal. Okay, now what is Wolff-Parkinson syndrome? Wolff-Parkinson syndrome is a disease or a pathological condition in the heart, which is due to an abnormal conduction pathway. There is a normal conduction pathway in the heart, which is regarded as bundle of Kent. What happens that normally your electrical activity is slowed down in the AV node, right? But in this condition, your heart got an extra accessory track to relay down the current from atria to the ventricle, and that accessory pathway is called as bundle of Kent. Now, what happens that due to any trigger or any due to any trigger or any condition, when this current is conducted through bundle of Kent, okay, First of all, it is not slowed down. Listen very carefully. What happens that normally the current it is slowed down in the in the AV node. But if the current is being conducted via bundle of Kent, it won't be slowed down. So it creates tachycardia, right? It's altered the rhythm of the heart. But let's go deeper that how it actually happens. So now when the current passes through a bundle of Kent, it goes to the ventricle, and then it goes to the AV node, okay, and then to the atria. Then from the atria to the bundle of Kent, to the ventricle, to the AV node. Again, from the AV node to the atria. Now, what happens that there is a loop now. So this loop keeps on firing or keeps on contracting. This makes the heart keeps on contracting at a very rapid rate, and this predisposes the patient to tachycardia. Right. So this is how the formation of tachycardia take place in the Wolff Parkinson White syndrome. What I have just explained you, it is called as if I'm not wrong, if it is called as antidromic, and there is another thing which is called as orthodromic. So orthodromic is just a reverse of that, in which the current is conducted from the AV node to the ventricle, then to the bundle of Kent, then to the atria, then to the AV node, ventricle, bundle of Kent, back to the atria. So it also creates a loop, and it also leads to, ventricular tachycardia. But that's different from what we're seeing. And in the antidromic pathway, or in the antidromic tachycardia, we see delta wave, but in the orthodromic we can't appreciate any delta wave. Anyways, leave that orthodromic antidromic. It's not the part of our discussion, and it's not the part of discussion of your step 1 exam. So that's all about this first question. So now what happens, I've just explained you that what actually happened. And yeah, I think that we got the answer here. So let me just conclude this case, that what actually happened in this case, that the patient had tachycardia, and that tachycardia has led to syncope, and that's it. Because you know that whenever there is tachycardia, heart is contracting at a very fast rate, and heart is not relaxing. If the heart is not relaxing, there is not enough blood in the heart. So no blood, no enough blood, so heart can't eject out enough blood, so that leads to syncope. Okay, so A is our answer. Of course, I have explained you. Now why not B? Okay, so degeneration of conduction system, fibrotic degeneration of conduction system, it happens in elderly individual. So this is a young boy. It's not the case here. Ectopic atrial foci, ectopic atrial pacemaker. So you would expect certain you would expect an abnormal P wave in such case. So remember, atria coincides with the P wave, so you would expect some abnormal P wave there. Okay, not this case. Why not D? SA node failure, my friend, it leads to bradycardia, not tachycardia. And E, delayed ventricular repolarization due to ion channel dysfunction. I have explained that in previous video, and this is about long QT syndrome. So whenever there is any pathology in ventricular repolarization, that leads to pathologic QT interval, prolonged QT interval, more correctly, and that predisposes to long QT syndrome, or TDP, to Sardis Pontis. So yeah, we are done with this case. Now the second one, it's a short one. Okay, so it's not that difficult. And okay, in this scenario, what is actually happening, that a doctor has palpated a pulse of the patient along the medial edge of the left sternocleidoid muscle. And that's about, you palpate which artery you palpate. Of course, you palpate carotid artery. So now it has asked that the question is asking that which the artery has derived from which aortic arches. So you got different first, second, third, fourth, sixth. Let me tell you. From the first aortic arch, we got maxillary artery. First is max. From the second aortic arch, we got stapedial artery. Second is stapedial. You can remember from S. And from third, we have common carotid artery and proximal internal carotid artery. You can remember it as that A, B, C. C is the third letter, and so as the third aortic arch. Okay, arch of aorta from the fourth. So and pulmonary artery and ductus arteriosus, I guess, from the sixth one. Yeah, I think I'm correct. Okay. Our next question. So I can give you, can I? Should I? So I guess yes. You can read out the last line and and you can skim the options and then back to the explanation. You can pause this video. So, uh, yeah. So, which of the following most likely describe the path of the embolus causing this patient symptom? Okay, so you got a 71-year-old man present to the emergency department with sudden onset painless vision loss in his left eye for the past hour. He has history of coronary artery disease, hypertension, type 2 diabetes, mellitus. Okay, so remember for the rest of your life that two major things can cause painless vision loss. First of all, retinal detachment, and secondly, retinal ischemia. Okay, central retinal artery occlusion, CRAO. So this can cause painless vision loss. Okay, you can see his blood pressure is raised and pulse is for 72 beat per minute. Okay, examination reveals that he can perceive only hand motion through the left eye. Okay, fundoscopy shows a cherry rod spot in the macula surrounded by retinal whitening, classic buzzword for retinal ischemia. And cardiovascular examination reveals a left-sided neck parade. Again, it shows that there is some pathology in the carotid artery. Okay. Yeah. Let's move. So you can see that this elderly patient is present with sudden painless monoocular vision loss occurring in one eye only. So cherry red spot on fundoscopy and a neck prit is heard. So that's a classic sign of central retinal artery occlusion. Now, what actually happened in that patient? That the brit in the neck suggests that certain atherosclerotic disease, and you can see the history of the patient. He is a smoker, type 2 diabetes, mellitus, and having hypertension. So the history also is significant for the atherosclerotic disease. So the brit in the neck suggesting atherosclerotic disease. Now the atherosclerotic plaque might have ruptured, and a part of that plaque can embolize to block tiny retinal arteries. So now the question is asking you, what is what's the pathway? So you know very well that whenever the you know that you got from the arc of aorta, and that arc of aorta gives rise to common carotid artery, and that common carotid artery divides into external carotid artery and the internal carotid artery. So remember for the rest of your life that internal carotid artery is the artery that supplies intracranial structure. Okay, and external carotid artery is the artery that supplies extracranial structures like face and skull. So all the options with external carotid artery are wrong. Why? Because retina is something inside your brain, not outside your brain, right? So it's something intracranial. So when we are concerned with retina, so we're gonna talk about internal carotid artery, not external carotid artery. I've explained, giving you the picture here. Okay, now yeah. So now, what's the pathway? Of course, internal carotid artery, when it enters into the brain, it gives off some branches to circle of Willis, like ACA, anterior cerebral artery, and it also gives off branches to the ophthalmic artery. Actually, it gives off a branch which is called as ophthalmic artery, and that ophthalmic artery give rise to central retinal artery and other artery around the eye as well. But these are not a concern. So, yeah. So the plaque might have traveled from the internal carotid artery to the ophthalmic artery, and from the ophthalmic artery to the retinal artery, and has led to the retinal ischemia. Okay, so the answer of this question should be uh, D? No, of course not D. It's E. Okay. It's E should be the answer. Okay. Why others are wrong? Of course, my friend, external carotid artery mainly supplies face scalp structure, not the retina, as I've explained you. And the anterior cerebral artery, which is written over here in the option D, it supplies the brain, not retina. Okay, so yeah. Moving towards the next question. Okay, that's my favorite question. Again, if any you know X-ray is given you, so first look at the X-ray, and then to read out the question. So if I look at the X-ray of this patient, it's suggesting me certain things, and I'm gonna explain you those things later. But right now, you just look at the X-ray and try to understand what's actually happening. Okay, so let me start from this case. Okay, a 4-year-old man presents in the emergency department with worsening shortness of breath over the last 3 days. Initially, his symptom occurred with exertion, but now progressed to being present at rest. He could not sleep last night due to a suffocating cough whenever he tried to lie down. You know, the symptoms of this patient are like shortness of breath that is now worsening, right? The major concern of this patient, you can see that shortness of breath, shortness of breath. Every time he's explaining, he could not sleep, he could not do that. The shortness of breath, the symptoms occur. So yeah, so the patient is having shortness of breath, and that is progressively worsening. My friend, that's a classic scenario of congestive heart failure. Remember for the rest of your life that whenever there is worsening of shortness of breath, it's a huge giveaway of you know of what of a congestive heart failure. Okay, so yeah, now you can see in the X-ray that I can, yeah. So now this is the X-ray. It's not the actual figure from here, but it's the both are explaining the same thing. So in the chest X-ray, you can see now. First of all, let me tell you what actually happened in the congestive heart failure. Then we will. Then I'll explain you the X-ray as well. Okay. So yeah. Again, now in this patient, you can see that what actually happened. Sorry. Excuse me. I was a bit lost. Okay. Now, what actually happens in the congestive heart failure, that heart is not being able to pump blood in a very proper manner, right? So, whenever the heart is not able to pump blood significantly, so you can imagine it as that something has clogged down, right? Like your sink has clogged down. So whenever sink is clogged down, what actually happens, man? You know that the fluid is starting backing up. So same happen in the decompensated heart failure or congestive heart failure, that the fluid is not being pumped into your circulation correctly, and it is start building up, and that leads to the pleural effusion in the chest on the chest X-ray. So you might ask that why the blood pressure is elevated. Let me explain you. You might say that a moment ago you were saying that your heart is not being able to pump blood correctly, and now you are saying that and in the in our case scenario, blood pressure is elevated, pulse is elevated. Why is that happening? Now let me explain you that. Okay, I have told you that in congestive heart failure, we have fluid overload, right? You know, the the blood is being backed up, and there is fluid everywhere, fluid in your chest, right? Remember the congestive heart failure as fluid in your chest. Okay, so this elevated blood pressure and increased pulse suggests volume overload, and the body's compensatory response to reduce cardiac output. Okay, so think of this elevated blood pressure as the body's response to increase cardiac output. Okay, think of that what is actually happening, that you can see that this diastolic blood pressure is normal, is okay, yeah, sorry. So you can see that in this scenario that the blood pressure is elevated, right? Not just look at the diastolic, look at the systolic as well. So you can see that in this case the blood pressure is elevated, and that blood pressure is suggesting that body is now trying to compensate the reduced cardiac output, and that reduced cardiac output is due to congestive heart failure. So, what the actually giveaway in this question is that the blood pressure is not always a reliable option to diagnose uh, the decompensated heart failure, right? All you have to rely on chest X-ray at times, and you have to rely on the history of the patient. So remember, for the rest of your life, whenever there is any, whenever there is worsening of dyspnea, right, worsening of shortness of breath, so just think of that as congestive heart failure. Okay, so now let me explain you the chest X-ray finding of this patient. Okay, so first of all, pleural effusion. So what it is, pleural effusion is fluid in pleural space and typically seen as blunting of costophrenic angle. So you can see that costophrenic angle. What are the costophrenic angle are? How should I explain you? Okay, so you can see your screen. Okay, the left lower part and the right lower part of your screen is representing costophrenic angle. Okay, so why the blunting of costophrenic angle? It is due to increased hydrostatic pressure that leads to fluid leakage into the pleural cavity, and that's why you can see blunting of costophrenic angle, and that's why you can see pleural effusion here. Okay, cephalization of vessels, what does it mean? It means that with a redistribution of blood to the upper lobes. Listen very carefully. Why it happens? It happens because pulmonary venous pressure rises, and upper lobe veins, which are normally smaller, they become engorged. So the cephalization of veins, which is shown in green, it indicates venous hypertension, pulmonary venous hypertension. Now, what are curly B lines? These lines are thin horizontal lines shown in the purple at the lung periphery and typically at the basis. And they appear due to interlobular septal thickening due to due to fluid buildup. And that's what they are. But remember, that's these curly B lines and cephalization of vessels, they are not almost always present. They are just for your step one exam, but in the real deal, they are not present. It's a very low sensitive finding, very specific but very low sensitive. So they are not always present. But if they are present, so they strongly suggest that there is nothing else than the pleural effusion. Okay. So yeah, interlobular septal thickening happening in the curly B lines. And now, okay, what's next? Increased cardiothoracic ratio. Okay, another important giveaway, which is always present, always present. Increased cardiothoracic ratio means cardiomegaly. It is always present in the decompensated heart failure, and it's a huge giveaway. Huge giveaway. Whenever there is increased cardiac thoracic ratio, don't think of anything else. Just think of your decompensated heart failure. Okay, so that's about these X-rays. Okay, so of course our answer, I've explained you the multiple times. So of course our answer is option A. Okay, option A is our answer. Now, why not the other answers? Now, let me explain you that. So, yeah, okay. Or B, option B was ARDS. Okay, so in ARDS, always remember, first of all, in ARDS, there might be a history of trauma or any infection. Okay, and not always trauma, but infection should always be must always be present if you are diagnosing ARDS, especially in adults. Of course, it happens in adults, and RDS presence in neonates. Anyways, so yeah, so in ARDS we have whiteout X-ray, and you can see the difference between the ARDS X-ray and the CHF X-ray. So huge difference. Okay. In idiopathic pulmonary stenosis, which is pulmonary fibrosis, which was our option C, we have reticular opacities not shown here. We have honeycombing appearance, which is classically shown on CT scan, and high resolution CT scan, not on chest X-ray. But you can appreciate traction bronchiectasis here. You can appreciate that there is dilation of bronchioles, which is represented as reticular lines here. The liney appearance, the granular appearance. So it is due to traction bronchioles. It is due to the traction on bronchioles, which happens due to fibrosis. So again, there's a huge difference between the X-ray of idiopathic pulmonary fibrosis and the congestive heart failure. Okay, so COPD X-ray, the option D. Okay, I was not when I made this whole presentation, I was not trying to put any X-ray of CH of COPD, because remember COPD got no X-ray classic X-ray finding. COPD rarely COPD is shows something significant in X-ray, but in certain cases we see flattened diaphragm, which is shown here because of hyperinflation. Due to inflation, there is pressure on the diaphragm, which leads to flattening of diaphragm. But again, it is not always present. Very low, very low sensitive, but very specific. Okay. Now pulmonary hypertension. So in pulmonary hypertension, you can see enlarged pulmonary arteries, which is written here has dilated pulmonary arteries, especially the right pulmonary artery, and right-sided heart enlargement, and increased pulmonary vascular marking, especially in advanced disease. So leave out that pruning thing. It's the same thing with different words, with different vocabulary. Don't worry about it. Okay, tension pneumothorax. Tension pneumothorax got a classic X-ray of depressed hemidiaphragm, of collapsed lung, and what happens in tension pneumothorax. There is air in lung, and the other part of lung, and the lung actually it collapse. It collapsed due to leaking of air, right? So the air in the lungs is released into the pleural space, and that leads to the tension pneumothorax, air in thorax. Okay, so it shows collapsed lung, and collapsed lung are represented as, or they are marked as, absence of any lung marking, and mediastinum is often shifted away from the collapsed lung, and elevation of diaphragm on the affected side. Sometimes there is depressed, and sometimes there is elevated diaphragm. So deviation deviation occurs in different cases from the classic findings. Okay, now the last question of our series. Okay, so yeah, read out the last line and then skim the options. Okay. So, a 55-year-old man presents for follow-up of his hypertension and coronary artery disease. Despite multiple medication, his blood pressure remains suboptimally controlled. Okay, I guess this should be uncontrolled. Anyways, his physician is considering this should be uncontrolled. Oh, no, no, it's correct. Suboptimally controlled. Okay, it's fine. I thought that only control is written. Okay, remain suboptimally controlled. His physician is considering adding verapamil to the regimen due to its vasodilatory effects and ability to reduce systemic hypertension. Verapamil also has negative inotropic effects on cardiac muscle, but notably spares skeletal muscle. Which of the following explain why skeletal muscle remains largely unaffected by verapamil? So the question is asking only about the mechanism of verapamil. It's not asking about anything to the patient. So the above explanation was a waste of time. Okay, so that's why I say that read out the last line. It gives you an idea what is actually happening in the question, and it saves your time as well. Okay, so before really explaining the answer, you have to first understand the mechanism of action of verapamil. So verapamil is a L-type calcium channel blocker. It reduces calcium influx into the muscle cell, especially cardiac and smooth muscles, and weakens contraction. We all know that. So why the skeletal muscle is spared? Skeletal muscle does not remember, listen very carefully. Skeletal muscle does not depend heavily on the extracellular calcium to contract. Instead, when a skeletal muscle fiber is activated, it triggers a massive release of calcium from its own sarcoplasmic reticulum, internally stored calcium, not relying on external influx through L type channels. So, therefore, even if verapamil blocks calcium entry outside, even if it blocks it doesn't, but even if, let's suppose, even if verapamil blocks the calcium entry um, uh, from the outside, calcium skeletal muscle contract just fine because it already has huge internal reserve. So that's why our answer should be yes. So I'm not gonna tell you answer here. I guess you guys should tell me the answer, man. I'll explain you enough that what should be the answer. But of course, I can't live without telling the answer. So answer is of course option E. Okay. So let's talk about option A, calmodulin independent excitation contraction coupling. So that happens in a smooth muscle, not skeletal. So of course, this is not the answer. Decrease troponin affinity to intracellular calcium. So skeletal muscle requires troponin binding to calcium. Decreased affinity would impair the contraction, but it's unrelated to verapamil. Okay, so elaborate T tubular system. Okay, T tubules help spread the action potential into the muscle fiber, but don't explain the resistance to calcium channel blockers. So again, not the answer. Finally, we have option D, lack of intracellular automaticity. Automaticity is about self-limiting, seen in cardiac pacemaker cell. Skeletal muscle relies on nervous input. So this is unrelated. So this concludes our module of episode 6, and see you in the next. Thank you.